of Ceremony in Visiting Lecture of the Epidemiologic Study in Research Limited Setting, held by Epidemiology Master Program, Faculty of Public Health, Universitas Diponegoro. Okay, in this meeting, I'd like to welcome the Honorable Dr. Weber Sabiti as our speaker today. Good morning, Doctor. Okay, and I'd like to welcome the Honorable Vice Dean of Resources of Faculty of Public Health, Dr. Mursid. Good morning, Dr. Mursid.
Yeah, good morning. Assalamualaikum.
Salam. Okay, and I'd like to welcome the Honorable Head of Epidemiology Master Program, Dr. Fauzi, and all the respectable lecturers and participants. Now, I'd like to invite Dr. Mursid as the head of Epidemiology Master Study Program to give us opening speech and also to open this agenda officially. To Dr. Mursid, please, time and place is yours.
Yeah, thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone, and good early morning, yeah. Dr. Wilber Sabiti, early morning.
Good morning. Very early.
Okay, okay. When good to sleep, ya, and dreamer to you. Okay, baik. The Honorable Speaker, Dr. Wilber Sabiti from University St. Andrew, United Kingdom, the Honorable Mr. Fauzi and Dr. Martini, maybe they are the lecturer as a chairman of a committee, and the student, audience, and who has come to the event for accepting the invitation. Thank you very much. In this happy day, let us praise the presence of Allah, who has given His grace and guidance to us. Because His grace, we can gather in this day the event of the visiting lecture. In this with great pleasure that I welcome you all to the visiting lecture on the essential and timely topic, about the epidemiologic studies and resource limiting setting. Epidemiologists, as many of you know, that is on the cornerstone of the public health, and understanding how to conduct research studies in the setting with the limiting resources, and is the key of the addressing global health disparities. And this morning we are fortunate to have with us today to distinguished expert, Dr. Wilber Sabiti from the School of the Medicine and University of St. Andrews. Dr. Sabiti is extensive work in the field of the infectious diseases, and his innovative approach of diagnosis and epidemiology research has a significant impact, on health care and the region, and face considerable resources constraint. His research has particularly focused in diseases such as tuberculosis, where innovative solutions are crucial for saving life. Today, Dr. Sabiti will guide us through the challenges and opportunities conducting epidemiology studies, and environmental resources may be scarce, but the need of public health intervention in immense. He will share us insight from his own research and experience, demonstrating how we can develop strategies to overcome these barriers of the approved health outcome the vulnerable of the population. I encourage on your engaged activity, ask question, and takes opportunity in this learn from Dr. Samiti, when global health. I represent of the Dean of the Faculty of Public Health. Also invite Dr. Wilber Sabiti to direct come to Diponegoro University in Semarang, in Indonesia. Please you come because we have currently hitting out with the world-class university. So collaboration with you and the other partner in the foreigns are very, very helpful for Universitas Diponegoro. And by say Bismillahirrahmanirrahim, with the permission of the participant, I officially open this visiting lecture of Master of Epidemiology Study Program. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much, Dr. Musrid, for the speech. Now, if you don't mind, please stay for the photo session. And I'd like to invite to Dr. Wilber and also Dr. Fauzi and all the participants to open your camera and give your best smile. I have the operator here, Shifa, to help us with the photo session. Okay, now I will count 1, 2, 3, and let's start with the first slide. 1, 2, 3. Okay, next slide. 1, 2, 3. Okay. Okay, now we have our photo session, and now I want to inform to all the participants to fill your presence on the link shared in the chat section and to rename yourself into name underscore institution or organization. Okay. Now, last week we learned with Dr. Lily on how to conduct epidemiology research on infectious disease, and in today's agenda, we'll discuss about various topics regarding infectious disease and antimicrobial resistance with Dr. Wilbur, and epidemiology study in a limited resources setting. Now, a brief introduction to our professor. Okay, maybe next slide, Shiva. Okay, so here we have Dr. Wilbur Sabiti. He is now the principal of research fellow in medicine, associate or associate professor in School of University of St. Andrews, UK. And Dr. Wilbur already have 48 publications in total, and mainly discuss about antibiotic susceptibility and tuberculosis regarding diagnosis, treatment, and monitoring, and also COVID-19 and other infectious diseases. And this is the recent publication in 2023 to 2024. Maybe that's the brief introduction to our speaker today. And to help with our discussion, I'd like to invite Dr. Fauzi as our moderator today to facilitate, guide, and review our discussion. To Dr. Fauzi, please, time and place is yours.
Thank you very much, Vina, for the mastering the ceremony for today. Good morning, Wilbur. It's been a while.
Yes, good morning. It's really very early here and cold.
Yeah, true. How are you, Wilbur?
I'm fine, yeah.
Is everything okay in the UK?
Yes, it's getting cold now, but otherwise, no disaster.
Okay, Wilbur, thank you so very much for accepting my offer to give a lecture to my students. Okay, Wilbur, before we begin your lecture, I just want to introduce the aims of this lecture to the students. So, all the students, this is Dr. Wilbur. Dr. Wilbur Sabiti is one of the experts that I've ever known in the UK, working with many infectious diseases, especially tuberculosis. And as I know, he works a lot about the biomarker study and then the drug resistance of tuberculosis and other epidemiologic study about the infectious diseases in Africa. So if you have any questions about the epidemiologic study in resource limited setting, then this event is a good opportunity for you to ask how to conduct a thesis in the infectious diseases in resource limited setting, like in Indonesia. We have very limited resources, but we want to get the good results, high quality impact results. So it's better to ask to Wilbur directly how to conduct research in epidemiology with the high quality, but in the so many constraints. And then Wilbur, you have more than 1 hour to give a talk, but if you're tired, then you can stop anytime. And then after your lecture or in between your lecture, you can accept the question and answer session. It depends on you and also the question in from the students. Okay, Wilbur. And then without further ado, I think it's better to hear directly about your lecture to the students. Are you ready to present your presentations, Wilbur?
Yes, thank you. And I'm going to share my screen. And okay, it should be this.
And also congratulations for your positions, Wilbur.
Thank you. I have many positions now. I'm about to ascend to another one. See you later in congratulating me.
Okay. And also, Wilbur, if you have a time, and then if I have a little budget from the university, I really want to invite you to come to Semarang.
Yeah, I would be really love to come over there. And as I said, I will be in Bali
Mhm.
in I think 2 weeks' time.
Okay.
And I will spend a week in Bali. I don't
Mhm.
know how far is Bali from Negro.
Yeah. Yeah, it's not really that far. It's about an hour to take a plane to Semarang. And yeah, I will talk later with you about that things, and then you can come over maybe to Semarang. It's really nice to have you in Semarang directly in person.
That'll be very good. So let's get started. And I've been introduced. I am a principal research fellow in medicine, or the associate professor in the Division of Infection and Global Health at the School of Medicine, University of St. Andrews. So these are my contacts. I'm on Twitter, which they call X these days, and also have Google Scholar here and ResearchGate, so where you can find me. So I'm happy to be with you on this 31st of October, 2024, very early in the morning here in Scotland. It's now a few minutes after 3 a.m. And so just want to take 1 minute of yours to talk about the University of St. Andrews. So University of St. Andrews was founded in 1413, and it is the oldest university in Scotland and the third oldest in the English-speaking world. So that means after Oxford, Cambridge, St. Andrews is number 3 in terms of age. But in terms of performance, the University of St. Andrews is number 1. And so we've beaten Oxford and Cambridge for the last 3 years. So they are fighting very hard to get back the first position. And hopefully we will not allow them to take it back. And so it's one of the 25 ancient universities that are still in existence. So as I've said, it's number 1 in the UK for the last 4 years. So the University of St. Andrews is made mainly of schools and a few colleges and faculties. So I belong to the School of Medicine, and this School of Medicine has offered preclinical training since the founding of Dundee University in 1967. So when the University of Dundee, which is our neighbor across the river, was founded in 1967, the government at that time made a deliberate move to stop St. Andrews from offering medical degrees. And I think the purpose was to protect the young university Dundee so that it could get good students and prosper. Otherwise, if they had left it to compete with St. Andrews, St. Andrews would have taken all the students. So for many, many years, until 2022, the University of St. Andrews was not allowed to offer primary medical qualification. So we would have students who would come and study for 3 years, and they get what they call a Bachelor of Science in Medicine. And then they would move on to the University of Glasgow or University of Edinburgh or University of Manchester to do their clinical training. But as of 2022, the law was repealed by the Scottish government, and now the University of St. Andrews is able to offer medical degrees, and we've already started our 5-year program in Bachelor of Medicine. So I welcome all of you in Indonesia to come and study medicine at the University of St. Andrews or even other programs. We were lucky to have Mohammed with us. He was an excellent researcher. We want you back. Your boss is retired, so you need to come and take her position. We no longer have a malaria expert. So in 2026, we will be fully fledged with a 5-year program students. So Dr. Fahuz gave me a synopsis of what I should talk about in this lecture. It was quite full. I was like, is this going to be covered in 1 hour or in 10 days? And so I tried to kind of summarize it in learning outcomes, and I will do my best to touch the topics. But where we miss something, we can always come back and fill the gap, so questions can bring it up. So our learning outcomes is one of define the basics of epidemiological inquiry, describe epidemiological study design, explain the application of study designs to research, especially in low resource limited settings, define triage concept and how to apply it to epidemiology, explain methodology for sample and data collection, give examples of possible epidemiological research questions from master thesis, and touch on the role of epidemiology in conducting antimicrobial resistance. So the topics will include epidemiological study designs, triage epidemiology, community sample collection, sampling techniques, basic epidemiological measurements, and application to research, surveillance data and use in research, antimicrobial resistance from basics to epidemiological research. So if you have a question, just raise your hand, or if I'm going very fast, just tell me that you're going fast. So basics in epidemiological inquiry. So the basic definition of epidemiology is the epidemiology is the study or scientific, systematic, or data-driven of distribution. So that distribution may include frequency or pattern, and determinants. Determinants are causes, risk factors of health-related states or events, or not just diseases, because it could be other conditions in specified populations, age, a neighborhood or a school or a city or a county or a state or a country or the whole world, and the application of this study to control of health problems. So it's a wide discipline. It's one of the oldest disciplines in medicine. So what are the factors that influence epidemiological, or what we call spread of diseases? So it's very important to understand the influence, the factors that influence the state of epidemiology if you have to really do a good study. One, what is the disease type? Is it a communicable disease? For example, infectious, meaning that is widespread, or non-infectious or non-communicable. So that means it's just localized and it might not spread from one person to another. If I sit around you, I will not catch the disease. But if it is infectious, maybe I might catch the disease by getting into contact. Or it is spread by a vector which may transmit it from you to me. Then the mode of transmission is very important in epidemiology. For example, is it transmitted by air? Is it transmitted by water? Is it transmitted by contact? So air, the most recent culprit was COVID-19, which was an air-transmitted disease. And you saw how difficult it was to control because people are breathing in and out, and this disease was spreading. So knowing the mode of transmission, you can easily design the control. And you know how we got it wrong in COVID. In the early days, they were saying, just wash your hands. And people washed their hands because the knowledge at that time was like, oh, it's only spread by contaminated surfaces. So people washed their hands. And later they discovered, oh, this thing is aerial, it's coming through the nose. And that's when they started saying, okay, now you can start using masks. So you can see how misunderstanding of the mode of transmission can lead to poor control of the disease. There are some diseases that are transmitted by water. So if you know that the water is where the disease is passing through, then you know how to make sure that that water is cleaned or is disinfected or boiled to kill the bacteria or the parasites. Or transmitted by contact. A number of diseases like Ebola, like Mpox now, which is a big problem now in parts of Africa. Those are transmitted by contact. When you contact somebody who has it, you also get the disease. Now, genetic composition, immunity, and nutrition. These ones are factors that determine susceptibility. As you may know, some people are susceptible to certain diseases and others are resistant. Even in COVID-19, we had people who got the virus, but they never developed any symptoms. They were happy walking around, no problem. Others got infection and had symptoms. Others got even severe disease and died of the disease. So the genetic composition of the host or the victims is very important in how the epidemiology works. If a population is more susceptible, it means that they are likely to have more problems with the disease. As you may have seen or heard, COVID-19 really affected European and American, North America, because these people did not have did not have good immunity against some of these infectious diseases. Environment. Environment is very important because human interaction with the surroundings matters. As I know, Dr. Fauzi used to study a malaria virus called Plasmodium norisci, which was commonly associated with the forest. And so people who went to the forest to either get some timber or do some other economic activity, they were exposed to mosquitoes that were vectors of that parasite, and they got that form of malaria. So the environment is very important because in most cases, it is a vehicle for transmission of the pathogens, or that's the pathogens are hiding in this environment. Behavior. Behavior is very important, especially human behavior. How we behave determines how the disease transmits. It could slow or accelerate transmission. You remember in COVID, we had lockdowns. And what was happening is the governments were trying to control movement of people, interaction of people, so that it would reduce transmission. So the behavior really influences how the disease transmits. We are learning now from about Mpox that a good amount of it is being transmitted through sexual relationships. So if we know that's the case, then we have to find a way, how can we limit those kind of relationships so that we cut the spread network. Pathogen virulence, very important. If the pathogen is more virulent, then it is likely to spread to more people, overcome the immunity of the victims. Vaccination status. If the community is vaccinated and they have what they call this proverbial herd immunity, then they are more likely to resist infection. But when they are not vaccinated, they become more susceptible. So these factors very important to be aware of when planning studies or interventions. And when you're designing a study or an intervention, you know, okay, what is the context of this disease? So now we're going to look at what the best epidemiological terms, because it's very important to understand these terminologies if we are going to do a very good epidemiological study. Because if you don't know, then it becomes difficult for you to do high quality study. So we start with mortality rates. So mortality rate is an estimate of the portion of a population that dies during a specified time period. So I'm going to ask you a question. Which of the following should worry you? A, 50 people died from dengue fever. B, 50 people in Samarang city died from dengue fever. C, 50 people from Samarang city died from dengue fever in the past year. So which of the three should worry you? Please unmute and tell me what you think should worry us and the reason why you think so. I'm waiting for an answer. Between A, B, C, which one do you think should be a worry to us? I need volunteers, someone to volunteer to answer this question.
Siapa yang mau menjawab? Silahkan. Bapak Ibu semuanya, teman-teman.
Okay.
Mbak Santi.
Go ahead, Mua.
Yeah, so I'm calling the students. Mbak Santi, Wina, silahkan. They are too shy.
They are too shy to answer.
Yes.
I'm not saying. Okay, so you see, I'm going to go through the options. So if they say 50 people died from dengue fever, now that kind of information, you don't know. Where did they die from? I mean, did they die from in the sky? They die in Indonesia? Did they die in UK? Did they die? Where did they die from? So that information really, you can really do nothing with it. It's not really informative. Then B says 50 people died in the city of Semarang city. Now, yes, now you know about where they died from, but you don't know when they died. They could have died 100 years ago. So should you get worried if people died 100 years ago? So it has given you some clue, but the clue is not enough. So C gives us the right clue. It gives us where, that's Semarang City, and the time frame where they died. So they died in the past year. So that means, oh, last year in this city of Semarang, 50 people died of dengue fever. So I should really think about it. I should get worried. What could have killed them? Why did they die? What was the problem? So now you have some information because last year is quite near. It's the recent past. So there's a time frame and there is the area. So meaningful statistics for epidemiology should have a denominator population and a time frame. So in this case, our denominator is people in Semarang City, and our time frame is 1 year or the last year, just past year. So very, very important. Without that, the statistics are not meaningful. Now, what are the examples of denominators? So a denominator is a population at risk or under study in a given area over a period of time. So examples of denominators could be a health board. So that could be like a group of hospitals or a district. It could be a city, could be a province. It could be just a hospital, can be talking about patients in a certain hospital or healthcare workers in a certain hospital. It could be a disease register. You could talk about, okay, like if you're looking at data, you're saying, okay, the cases in the Samarang hospital register, and you are focusing on that. That becomes your denominator for any statistics that you do, or the people that you recruited to study. So if you recruit 1,000 people and 50 of them die, 1,000 is your denominator, and the 50 who died are the numerator. So it's very important the denominator must correspond to the numerator. That's very, very important. For example, if we say 50 people died in Semarang in the past year, and we want to calculate the mortality rate, we cannot use the population of Jakarta because this occurrence did not happen in Jakarta. So Jakarta cannot be our denominator. The denominator must correspond to the numerator. So where the event happened, the denominator should be from that place. Now, the second point on calculating mortality rates is the time frame. So time frame, this is the time that an event is measured. It could be 1 month, it could be 1 year, it could be 2 years. So that time frame, like we said for the previous case, last year was the time frame. So 1 year within which that event was recorded. So in epidemiology, you often meet terminologies like person time. So person time is an estimate of the actual time the person is at risk in years, months, or days. So that's the time the person is at risk or is under study. Or there's an intervention where it's being intervened, is given the either a treatment or any other remedy. It is calculated by multiplying the number of people to the time of exposure. So for example, if 1,000 people are exposed in a year, the person time is 1,000 person years. So we get 1,000 multiply by 1 and get 1,000 person years. So you should not be scared when you read these numbers in epidemiological literature. So you could say 10 deaths per 10,000 person years. So this can be broken down or explained as 10 deaths out of 10,000 people in 1 year or for 1 year. Or it could be 10 deaths out of 5,000 people for 2 years. Or it could be 10 deaths of out of 2,000 people for 5 years. Then we have what we call N-year follow-up. So this is the time frame of an exposure or outcome. The time that is taken on an exposure or with an outcome. We will soon talk about what an exposure is and what an outcome is. So you can talk of, for example, 5-year mortality of 10 per 10,000 people. So that means within 5 years, in a population of 10,000 people, only 10 people died. So as we said, without a denominator population and time, mortality rates are meaningless. So we must have a denominator population and the time frame. So please note that. Now, another important epidemiological terminology which you come across quite often, especially you who are studying epidemiology, is incidence. So incidence is the new cases of an outcome, e.g. disease, infection, etc. Just new cases that are appearing or emerging. So the number of new cases, so we can talk of, say, person time, in terms of incidence. So 5 cases per 10,000 person years. So that means that either these were there were 10,000 people and 5 of them died in 1 year. So 10,000 times 1 year gives you 10,000 person years, and only 5 of these people died. So the incidence rate equals the number of new people with outcome over time period divided by the total number of people in the group at risk times 100,000. That is now the, if you want to put your incidence at the threshold of 100,000 population. You can even put it at 10,000 or even 1,000 population. And the then the other very common factor is what we call prevalence. So prevalence is the proportion of population that has the disease. So for example, we can have what we call point prevalence. That is prevalence that is estimated at a specified time. E.g., for 1% of population had chronic obstructive pulmonary disease in 2010. So that in that year alone, that was the prevalence. So that was a point prevalence. If we estimate the prevalence of tuberculosis in, say, in the province where Samarang is, at that point, that's called a point prevalence. We've done it in 1 point of time. But there's what we call period prevalence of time. So it could be a lifetime prevalence over maybe 10 years or 20 years, 40 years, something like that. So what is the difference between incidence and prevalence? So incidence is a rate or a proportion. So incidence can be a speed at which new cases are appearing, or it can be a proportion of the population that of new cases in the population. Prevalence is a proportion. So out of a population of Indonesia, how many people have tuberculosis? So that's just a proportion of the total population. Incidence is useful for identifying causes of diseases, because when a new case appears, you begin asking, what's happening? What's causing this case to come about? Then you go to investigate, so you find out the cause. Prevalence identifies the disease burden, like how many people are affected by this disease at this point in time. Incidence occurs by definition only in people without a disease. So it's something emerging in a population that did not have a disease, or somebody who did not have a disease. Useful for planning services, that is prevalence. Prevalence is good because you know, okay, how many people are sick? How can I plan for them? And prevalence also depends partly on incidence, because the higher the incidence, the higher the prevalence. Soon we shall look at what we call the epidemiological bus. So incidence or prevalence, what should worry us? That's my question to you. Hopefully somebody might want to answer that. What should cause us to worry? Incidence or prevalence? Like incidence is where new cases are appearing. Prevalence is where there are many cases of a disease in a population. Which of them should worry us?
Silahkan siapa yang mau menjawab, teman-teman semuanya? Dari insiden dan prevalence, mana yang kemudian akan menjadi atau bisa menggambarkan suatu keadaan yang lebih mengkhawatirkan di lapangan begitu. Silahkan teman-teman. Wina, I think Wina want to answer the questions.
Maybe they want to answer in their language.
Yes, Wina, I think.
They could answer in their language and you translate for me.
Sure, can. Wina.
Well, I think the answer is incidence, because if the new cases rises, then it might lead to outbreak, doctor.
Great, thank you very much. It could lead to an outbreak. That's true. If there are new cases coming up at a high rate, that could lead to outbreak and an epidemic. So we should be worried. But also, if prevalence is high, that means the risk of contracting the disease is also high. Like if you have a population of 100 people and 80% have got tuberculosis, then the risk of getting TB is also high. So high prevalence or high incidence, both should worry us. Now, this is the epidemiological bath, or what we call the epidemiologist's water bath. So behind the tap is diagnosis is taking place and new cases are being detected. So the more you diagnose, the more you detect cases, new cases, and so that's the higher the incidence. So this tap that is dropping water into the bath is incidence. So the drops are new cases coming in. Now in this bath, there are cases, people who are who have the disease. So that's its prevalence. Now, there are two things that will reduce the prevalence. One, on the positive side, is recovery. People begin to recover, and that might be due that there's improved medication, improved procedures of managing the people, or in improved rehabilitation, which leads to increased recovery. So this evaporation from the water bath is reducing the prevalence because of better treatment practices or management practices. On the negative side, prevalence can also be reduced by death. So some are dying because they cannot handle the disease, and or the other thing could be that management of the disease has been improved, especially like diseases like cancer, and so maybe someone's life is prolonged. Instead of them dying maybe in 1 month, they die after 2 years. So that means they stay in for a long time, and they survive at least before they die. So if you want to control a disease, you must make sure you find ways of closing this tap, because this tap is bringing new incidence cases. So wherever you are as an epidemiologist, your mission should be, how do I close this tap to limit the number of new cases that are coming? And if you are unable to close the tap, then what treatments, what interventions can you put in place to reduce the number of cases in this epidemiological bath, so that you reduce on the people who are unwell? So number of effect or outcomes that are normally talked about in epidemiology. I'm sure you have done them in your early stages of epidemiological studies. There are what we call sporadic cases, whereby it's occasional cases occurring irregularly, endemic persistent background level of occurrence, so low to moderate levels. Maybe I pause here and ask, what are endemic diseases in Indonesia? What do you call endemic? Should we say malaria is endemic?
Ada pertanyaan, apakah malaria sebagai penyakit endemik atau tidak? Siapa yang mau menjawab, silahkan. Mbak Santi. Wina. Apakah malaria penyakit endemik atau tidak?
Menurut saya endemik, Pak.
So she said endemics for the malaria, Wilbur.
All right, thank you. And I'm sure there are also other diseases that are quite endemic. So those are diseases which exist in very low prevalence. They are not like, you may not sometimes recognize that they are there, but they are just like a few cases. But then when the number of those cases begin to go above the endemic level, that becomes an outbreak. So greater than expected cases of the endemic levels. That's what we call an outbreak. And you can only detect an outbreak if you have good surveillance systems. So that's the purpose of this lecture. How do we detect these new outbreaks quite early? It's putting in place surveillance, genomic surveillance, diagnostic surveillance, and try to make sure that you are checking at least a certain number of samples that are going to healthcare facilities to check what is being detected. So any new case, then you can easily detect that there's something that is going beyond the levels that you often detect. But if you don't have any baseline data, you don't know whether this is an outbreak or not, because you don't have any data to show what is normally regarded as normal level. Then epidemic is occurrence in excess of the expected level for a given time period. So disease, in this case, the disease is spreading rapidly over a larger geographical area and involving many people. So COVID started as an outbreak and then became an epidemic, spread to more parts of the country, of China. And then later, it started spreading to other countries, and then it became a pandemic. The same has happened with Mpox. So Mpox, there were cases in Europe and North America, and then they sort of got controlled. But then in Democratic Republic of Congo, the Mpox since 2022, they stayed in there at low levels, but the international community thought, oh, this is gonna just go away like it did in Europe and America. It didn't. It stayed and spread to the whole country. And then of recent, since June of this year, it has now spread to like over 10 neighboring countries, and more new cases have emerged. Since August, over 2,000 cases of Mpox have been confirmed. So you can see how it has rapidly moved, kind of transformed from epidemic to a pandemic involving other countries. And one of the drivers is emergence of new variant. So a new clade of Mpox, which is more transmissible, emerged, and it's more virulent, and it's been affecting more people and spreading very fast. So you remember what we talked about, the factors that influence the epidemiology. So if the virus is mutating or the bacteria mutating, producing new variants, the virus that come might be more virulent or more transmissible and be able to spread to many people in the shortest possible time. Now, I promised that we would talk about outcomes. So what are outcomes? So an outcome can be death. So this is sort of like the last outcome, because when you die, you die. That's the end of you. But it's an outcome. So a disease can either cause death. It can cause hospitalization. Like you're sick and you need to go to hospital. So you go to hospital, the doctor checks and says, oh, you are really bad off, you need to be admitted. You get hospitalized. An outcome can be a fast diagnosis with a disease. You go to the clinic, wherever, they take a sample, they do a laboratory test, and the outcome is that hey, you have malaria, or you have dengue fever, or you have what. So a diagnosis of a disease can also be regarded as an outcome. Or recurrence of a disease. For example, cancer relapses, tuberculosis, we know it also relapses after treatment. So a recurrence of a disease can also be regarded as an outcome. Or quality of life, something that compromises the quality of life can be regarded as an outcome. Or there are surrogates like high blood pressure, lung function. Those are also outcomes. So what about exposures? What are exposures? So there are two types of exposures. One is what we call non-modifiable exposure. This could be age, sex, or genotype. So genotype is like your genetics, your genetic composition. So these ones are not modified. If I'm 30, I'm 30. Like, I mean, I cannot change the age. If I'm male, I'm male. If I'm female, I'm female. If there's something in between, you are that. You cannot reach it. But recently, with advanced technology and and wherever people are attempting changing their sex, but it used to be a non-modifiable exposure. And of course, the reason why we talk about exposure non-modified is that, remember, age can expose you or make you more susceptible or resistant to infections. For example, we know that people over 60 years of age were more susceptible to COVID-19. Now we know that male sex is more susceptible to tuberculosis. So for TB, males are the most affected. Then the other things like genetic composition also that predispose people to certain diseases. Then there are what we call modifiable exposures. So this is like smoking. So smoking, you can just decide to stop smoking and it won't be an issue. Weight, you could do like without eating or take some slimming tablets or whatever and reduce your weight or do exercise. So there's something you can do on weight and modify it. Diet, you can modify your diet. Alcohol consumption, you can decide you're no longer going to take alcohol, and that's it. So these are what we call modifiable exposures. You can do something about them and change them. Then there are interventions. So if you have an exposure, what kind of intervention? You can get drug therapy, you can get surgery, or you can get lifestyle advice on how to handle your life and be better. Now, there are other epidemiological terminologies. One is, and these are now commonly used, especially since COVID-19. You've heard of case fatality rate. This is a proportion of cases of a specified condition that are fatal within a specified time. We have what we call infection fatality rate. This is the infection fatality rate is the proportion of cases of a specified condition that die divided by the total infected people. So that's the infection fatality rate. Then we have what we call infection rates or the reproductive number, ARA. In COVID-19, you must have heard of that many times. They were always calculating the ARA of each variant and trying to estimate, make predictions whether there will be another wave or something like that, or whether they should have a lockdown. So infection rate is the rate at which the infection spreads within a population. ARA, or reproductive number, is the best reproduction number denoting the number of cases that can be potentially infected by one case where everybody is susceptible. So reproductive, for example, in some variants of COVID, like the Delta variant, they had a high ARA number. They could infect like 5. One case could infect like 5 or even 10 people. So that's what we mean by R. Then there are some cases, some variants whereby one case maybe infects one case. So the ARA is limited. And there's something you can do. The lockdowns were meant to break this reproduction rate, to reduce the ARA and suppress it, so that people are not interacting. So that means there's no chance for the virus or to find another victim. And that reduces the R. Now, let's come to our studies, epidemiological study designs. So there are 4 main study designs. It's what we call cross-sectional study design, which studies a proportion of the population at a given time. So at just one time point, you go and study a certain portion of the population. And that's the same as sort of point preference. You go at a period of time and conduct your study. We have what we call case control studies. Here you have cases with an outcome and you compare them to controls without an outcome. Cohort studies, they are studies of a group of people over a period of time for exposures and outcomes or outcomes. So you have a cohort or a group of people and you follow them up, you look at what the outcomes, those that do not have an outcome, and you check if they get an outcome along the way, and then you investigate what could have been the cause of the outcome. Randomized control studies, these studies involve a sample of the population in which the participants are randomly allocated to for an exposure or no exposure. So the allocation, the trick about randomized control trials is that the cases in each part are randomly allocated. Or whatever intervention you do, it's done by random allocation, so that is you avoid bias or any other factors that goes with purposive selection of participants. So I would like to request for a pause of 3 minutes so that I can get some water to drink and then come back. Is that okay, Muha?
Yeah, sure, Wilbur. Take your time.
Thank you.
Jadi istirahat dulu ya Bapak Ibu, karena Wilbur mau minum dan lain-lain.
I'm now back, and we can continue from where we stopped.
From the randomized control studies, Wilbur.
Yes, so yeah, so the last statement I made was about randomized control studies, which are the kind of the highest in terms of epidemiological inquiry or epidemiological study, because they do involve random allocation of participants to different interventions or treatments. And they are the most expensive studies, but it depends on what you are randomizing. If you say, okay, you want to look at certain maybe chickens that have Campylobacter in a certain village, then maybe and you want to randomize the intervention, it might not be as expensive. So it really depends on the question you're asking and the kind of treatments. If you are, for example, doing a study that involves a very expensive drug, then that study becomes very expensive. But if you are looking at something that is cheap, the study may not be as expensive. So we are going to look at each study one by one and give examples of what it does. But before we do that, I wanted us to first appreciate the hierarchy of evidence. This is very important, especially for you master students. You are training to become expert epidemiologists and advise on interventions, on policy and practice. So what kind of evidence do you use in order to inform policy and practice? So at the bottom of the pyramid, you have what we call background information or expert opinion. So that is really like low-level information. It might not really inform change of policy or change of practice. Then next level is observational studies, which are descriptive design such as cross-sectional studies, case series, case study. Those are like tier 2. Tier 3 is observational studies with analytic designs, such as cohort study, case-controlled study. Those are tier 3, can generate good quality evidence. Then you go to tier 4, which is what we call the quasi-experimental designs. These ones are like, they are not randomized controlled trials, but they're kind of half randomized clinical trials. So in quasi-experimental, the prospectively controlled study, or pre-test or post-test or historic or respective control group studies. So those are tier 4 studies. Then tier 5, you have experimental designs, which will include randomized controlled trials or pseudo randomized controlled trials. On top of the pyramid are what we call systematic reviews and meta-analysis. So the reason why systematic reviews are on top is because they have advantage of looking at evidence from different studies of different geographical backgrounds, different populations, different genetic compositions. So they have that privilege to look at all this evidence and sensitize it. So what they come out of, what they derive from this evidence is more robust and is more likely to stand the test of time and inform policy and practice. But if you do one study, the studies that we mentioned below on the pyramid, and it's, oh, I found something, we need to change practice. And then, so Wilbur found this today, and he reported and he asked for change of policy. Then Dr. Fauz later, he does a study, and his data shows that actually what I did, what Wilbur found was wrong. And now, but they have already changed the policy. So now they have to change again because they have been proven it wrong. So in order to prevent that, policymakers, practitioners, they always want robust evidence. They want to see what is the test of time. How has this data really been reported in different places to show that it's indeed leading to the same outcome or the same benefit? Then they can now change policy or change practice. But that is often not the case when you are in a situation like COVID-19, where we didn't have any data about COVID-19. So every small study that was coming out, the world was consuming it as if they were drinking water because they were hungry for data. And anything came out, they would inform practice or policy. But in cases of established conditions like tuberculosis, like malaria, like whatever, where there's been data, like hundreds and hundreds, millions of literature, you cannot just use one study and say, I'm going to inform practice. You need to synthesize many studies and come up with something that can be helpful and stand the test of time. So that's the pyramid or the hierarchy of evidence. The higher you go, that's systematic review, and then you have the bottom, which is less likely to inform policy and practice. Now let's look at these studies, cross-sectional study. So this is a study of a sample of a population at single point in time or short period of time. So you come, you say, I want to determine the prevalence of malaria in Samarang City. And you get all the tools, you recruit all your field workers, whatever, and maybe for the 6 months, you do your study and you come up with the prevalence of malaria. So that's it. It's a cross-sectional study. It ends there, and in what you get, the information you get, it's as useful. It's referred to that point in time. So this study, this kind of design, can be used to estimate the population with different exposures, modifiable or non-modifiable. So different exposures here, we mean age. You want to know the age of people in Jakarta that are susceptible to dengue fever. You go and find it out, and that's it. Or you want to find what's the genetic composition of that's making people susceptible to a certain disease, you go and find it out. Then this study can also be used to determine different signs and symptoms. Like you want to know what are the common symptoms for pneumonia. And you go out and you find cases, diagnose them, and then try and determine what are the clinical signs, which you can now use to inform future clinical diagnosis. It's done cross-sectionally and finished. It can also be used to determine different outcomes, either disease, sickness, or death, or antimicrobial resistance. Does this factor, or what is the level of the burden of antimicrobial resistance in a certain area? You go out there, you do your survey, and you finish. So the uses of the data from a cross-sectional study can be to describe prevalence or the burden of a disease, or to explore the association. Is malaria associated with going to the forest? Is dengue fever associated with urban centers instead of rural centers? Because as we've heard, there are more cases of dengue fever now occurring in urban centers than they are occurring in rural areas. And you may want to know, okay, is it because the vector AIDS mosquito? Is it because it has changed behavior and now it is now learned new ways of surviving within cities, which do not have bushes, but maybe there are other areas where the mosquito can hide? So that's like, it can help you to study like the behavior of a vector and its association with the prevalence of a disease. Methodology, in most cases, it's surveys. We use surveys. They could be randomized survey. You randomize you can say a city or a district, and then you kind of work out the sampling points, because you cannot sample the whole city, even if it's just Semarang, one city. You can't say, I will sample every point within this city. So in order to avoid bias and really get an informative result, you randomize this city into sampling points, and then you go and sample from those points. Or you can, based on the information that you already have, you can do purposive sampling, whereby you can work out based on the already known hotspots, prevalence. You can say, okay, I will sample there because we know there's a higher prevalence there, or there's a certain particular condition there. You can go and focus there. So that's what we call purposive sampling. But mainly cross-sectional studies are mainly surveys. I think you can also do a data-based study with cross-sectional design. If there's a large database that covers a population in a given period of time, you can also design a study that can be applied in that sense. Examples of research questions can be, what is the prevalence of antimicrobial resistance in province X? Or what proportion of university students are susceptible to malaria? Etc., etc. So a number of questions can be asked with a cross-sectional study. Now, our beloved case control study. So this study design compares cases with an exposure or outcome to controls without. So you have the cases that have an exposure and then or outcomes, and then you have controls on the other side that do not have this outcome. So in this case, the cases are a group of people with an outcome of interest, such as a disease or condition. Or you have intervened, and you call them maybe experimental side. You have intervened in that group with a special drug or whatever, and those become your cases. And then the controls, maybe you have given them a placebo, or they have not been intervening, or they are not exposed. So you have these two sides. So there must be cases and there must be controls. So a control must be a group of similar people without the outcome. So you should mark this. If I'm doing my study in Semarang, I cannot go to get controls in Jakarta. In order for these controls to be effective, they must be of a similar population, but what they don't have is that they do not have an outcome. And you're trying to find out what could have caused the disease in the cases who have an outcome. And what is special about these controls, what is preventing them from getting this kind of outcome? So it considers cases with an outcome versus those that don't have it. It explores exposures in cases versus controls. Exposure, as we said, this could be modifiable, such as smoking, alcohol, and other things, because you could say, okay, I want to look at what is the impact of alcohol consumption on tuberculosis prevalence. Is it that alcoholics are more likely to get TB, or they already have TB? So that's how a case control study works. But always remember, there must be controls. Do not come to me and say you are doing a case control study, but then you do not have controls. The controls must be there. There must be cases on one side and controls on the other side. It is normally used to compare exposures in cases and controls. It can identify association between exposure and outcome. For example, if my exposure is smoking, is this smoking causing lung cancer? So smoking is the exposure, lung cancer is the outcome. And examples of questions that can be asked could be, are patients with antimicrobial resistant infections more likely to die than those antimicrobial sensitive infections? So antimicrobial resistance in this case is an exposure, and death is the outcome. And then you can ask a question whether this AMR is likely to cause more deaths than those who are not AMR. And then you go into a study, or you can even do this one respectively. You go into a register, a hospital medical records, and look at the data back in time and say, oh, actually, people who had AMR infections died more than those who didn't have AMR infection. So that's how we can use our case control study. So do people who visit the forest more likely to contract malaria than those who don't? We had already talked about that question. Another important study design is cohort study. This is a more common study used because both case control and cohort study are not as expensive as the randomized trial. They are kind of manageable. And they can collect both retrospective data, so I mean data that was already there, or primary data. So cohort study compares a group of people with a similar characteristic over time to assess the effect of outcome or exposure. So you have a cohort. They are all unified by a certain characteristic, and you want to see, okay, if I expose them to this, what is what happens? What could be the cause of what happens? So it involves selecting people without an outcome, classifying those without an exposure. Then you have follow-up. The follow-up can be prospective, that means going into the future. to assess whether the outcomes are becoming frequent. Or it can be retrospective. You can go into the database if you have a database, or you can go to a hospital and ask them to give you the medical records if you have got the ethics approval. And then you can look back in time, like you can create a cohort out of that database and then look at it over time to see what could have been the causes and the outcomes. It compares risk of disease in exposed and unexposed. It can be done on with primary or secondary data. So primary data in this case can be new participants that are enrolled and followed over time. But as a student, sometimes you don't have money to enroll participants into your study. So what you can do is use secondary data sources. These are already collected, assessed prospect. These are already collected data sets, and they are assessed prospectively or respectively. So you can say, okay, I'm going to be looking at data. Maybe they have been monitoring adverse drug events of a certain disease being treated with a certain medicine. And then you can say, I'll be monitoring maybe every 2 months. I'll be checking at the hospital to see what kind of adverse events are being reported. And you do that one over time, going into the future. Or you can look at the data going back in the past. So there are many ways to come up with studies that are cheap, not expensive, but yield very good information. And in these days, we have many tools that are collecting data that you can use, that there are databases that can be taken advantage of. Then we have the randomized controlled trials. This is the gold standard for studying the effects of treatment or another public health intervention. So if there's you can randomize a public health intervention and then study the effects or the usefulness of your intervention. So the most important with randomized controlled trials that the participants are randomly allocated to different intervention, and then the control or the comparator arm. The usage or the usefulness of this kind of study design is it compares risk of outcome in intervention and control groups. It's more expensive study design, so the most expensive. Examples of questions that you can ask how effective is treatment Y in controlling malaria? Does the use of digital medicine boxes increase adherence to or completion of tuberculosis treatment? You may have heard that now currently TB patients are given these what they call electronic medicine boxes. So when the patient opens it, it sends a signal to the hospital to say, oh, the patient has taken their medicine. But if they don't take their medicine, no signal will go to the hospital, and the doctor will call to ask, did you take your medicine today? What is happening? So you can randomize that. I have a friend who did this work, I think, in China and Myanmar, where he randomized people that were using digital tools and was able to determine the impact of those digital tools on adherence and completion of tuberculosis treatment in Myanmar and China. Another question could be, does eating an orange a day prevent scurvy in a student population? So you can ask, this is a nutritional kind of study, but epidemiological in a sense, you can look at, okay, if people eat this kind of food, does it prevent them? You know, we are always told by everybody, oh, if you eat that food, you'll be okay. You'll be very smart. You'll pass all your exams. But does it really work? So you can assess it, design an experiment and assess it. So what are the objectives of these studies? So a randomized controlled trial normally will evaluate traditionally treatment effect. If you treated people, how efficacious, effective is the randomized controlled trial. A cohort, it can study cause of an outcome, prognosis, that is predicting outcome. You look at the patient and based on their symptoms and whatever, or a biomarker, you say, okay, you are likely to have a poor outcome, or you'll have a better outcome. So prognosis is a kind of trying to predict the future. Cohort studies can also be used to study incidence because you are following this group of people over time. You can record the incidence of new cases, say of dengue fever or any other disease that is of interest. Case control, its purpose mainly is to discover cause, what caused the disease, because you have the cases and you have the controls. The controls and cases are all the same, but you want to see what caused this outbreak. Prevalence, the cross-sectional can be used to study prevalence of a disease in a population, or what we call point prevalence. And the time frame, randomized controlled trials normally look to the future. Cohort of prospective and retrospective. The cohort and prospective, they look to the future. Retrospective cohort study looks to the past. Case control looks backwards to the past because the cases already have a disease and you're looking at if you can help them. Cross-sectional also can be in the past because you are studying what has already happened. So you are not intervening for an outcome to happen in the future. So Dr. Fauzi asked me to talk about triage epidemiology. And I explored to find what exactly is this word triage. So the word triage comes from the French word trier, which means to sort or to categorize, put in groups. So triage is utilized in the healthcare community to categorize patients based on the severity of their condition and by extension, the order in which multiple patients require care and monitoring. So that's what happens in the healthcare community. They are trying to group patients to say, okay, whom should we attend to urgently? Who can wait for later? Who should go to the lab to get this expensive test? Whatever. So they're kind of trying to balance up balls in that case. In diagnostics, triage is used to decide who needs rapid detection test, a more expensive confirmatory test, and or further clinical examination. So you're like, okay, who needs just this rapid antigen test? Or who needs to have a PCR, confirmatory PCR test, and who needs further clinical examination? So you have now triaged them, and now you help them in their separate needs. So now, in epidemiology, this is known as epidemiology triangle. It's a model developed by scientists to study how diseases emerge and spread. So the science developed this triangle to study how the diseases emerge and spread. Now, this is our triangle. One side you have the host, the other side you have the agent, and the other side you have the environment. So now the agent, this could be a microbe, bacteria or fungi or virus. It's the one who causes the disease, or what we call the what of the triangle. So the agent or the microbe is the what of the triangle. The host is the one who has the disease or harbors the agent. So he is called the who of the triangle. Then we have environment. Environment is the external factors that cause or allow the disease to transmit, also known as the where of the triangle. So we have the what, who is the agent or microbe. Then we have the who is the host or the human being who has been infected by this disease, and the environment, which is now the external factors that cause or allow the disease to transmit to where, and it's called the where of the triangle. So these factors are in interplay, and they link to the other factors we talked at the beginning that influence the epidemiologic state. So in an outbreak or epidemic, the mission of an epidemiologist is to break one of the sides of the triangle to disrupt the agent from the host or from the environment. So if you can successfully break one of these triangles, one of the ends of the triangle, then you manage to block the disease. Because if you block it from the host, that means that there won't be any other more diseases being spread around. If you break it from the pathogen, maybe there will be no pathogen spreading around. If you break it in the environment, then maybe there will be no pathogen come from the environment to attack the host. So that's what we call epidemiologic triangle. Very useful formation. Now, let's take a moment to talk about antimicrobial resistance, or AMR. AMR is the phenomenon by which microbes can no longer be killed by antibiotics or antimicrobials that used to kill them. So months before, years before, this antibiotic used to kill all the bacteria. Now, it's no longer working. That means the bacteria have devised means to be resistant. So antimicrobial resistance may emerge because of genetic mutations or tolerance. There are some strains of bacteria which tolerate the antibiotic, and the process of tolerating, they learn some new tricks of resisting the antibiotic. Antimicrobial pressure may induce genetic mutations, or what we call selection, for those that already have inherent resistance traits. So for example, the mechanism for resisting penicillin emerged before the invention of penicillin antibiotic. But that could be true or not true, because even though it was not a purified antibiotic in the environment, this penicillin was being produced by a certain species of fungi that live in the environment. So meaning that maybe the bacteria may have already been exposed to this fungal toxin, and they had already developed ways to resist it. So when they put it into when they made it an antibiotic, the bacteria already had got resistance, and they've resisted it up to this year. Now, just as I wind up, I wanted to just take you through the experience we had with our Hatua study in East Africa. It was an AMR study known as Holistic Approach to Unraveling Antimicrobial Resistance in East Africa, also known as Hatua study. So our purpose was to investigate biological and socio-economic, cultural, and behavioral drivers of antibacterial resistance. And we used urinary tract infection as the prism to answer these questions. So we did this one under the work stream of what we call disease and therapy landscape. And the questions were asking, what are the networks of antibiotic provision? Like, who are the people providing antibiotics? Where do people access antibiotics? Where do you go when you want antibiotics? Then what are the antibiotic access behavior? How do people behave? Do they go clinic first and then go to get antibiotics from the pharmacy? Do they go to traditional healer before they go to the antibiotic? So we were interested in knowing what behaviors they experience. The other question was, what are the attitudes and practices of antibiotic providers, like those pharmacies? I don't know Indonesia whether you have these small community pharmacies, drug shops, which are really very common in some parts of Africa and I think and India. So we wanted to know what is the attitude, what's their professional practice in providing these antibiotics. We're also interested in knowing the behaviors with higher risk of AMR. So in your population, you might be interested, what are the behaviors that may increase the risk of AMR? And then the other question was, what is the relationship between genotype and AMR? So the pathogen genotype and the antimicrobial resistance. What is the burden of antimicrobial resistance in this population that we study? Which AMR forms are most common? For example, is it the ESBLs or carbapenem resistant or streptomycin resistant or drug resistant or whatever? Which one is more, which form of antimicrobial resistant is it? So look, this is now a network. And the reason we designed this network, look at how things are interconnected. So we're studying urinary tract infection, and this is the patient. They've come from the clinic, and the clinic has decided that they should go for UTI examination. Now, apart from the patients, we also looked in the community where we would find those who are selling antibiotics at their shops and pharmacies. Then we had the patient who was being treated. So we explored all areas. Now, from the patient, we got the pathogen. Because those who have UTI positive, we took the urine, we isolated the bacteria, and then cultured it and got the pathogen out. And what were the purpose of this? Would go identification and burden of resistance, and then the other networks, patient and contacts. You see animals here, down here. you see issues like antibiotic history. Did they take antibiotics before? Did they have any clinical history? Did they have social demographic and social economic problems? And then you have behavioral social, and then reservoirs in the environment. We talked about environment a few minutes ago about the epidemiologic triangle. So what are the reservoirs? They human, animal, and environment. All that was explored. Then under genomics, we looked at whole genome sequencing, antibiotic sensitivity testing, then genetic then you have length of infection or origins of in the community. So you can see that there's a web of network of what involves in contributing to antibiotic resistance. So when you're thinking of antibiotic resistance, you should think in holistic terms. You have community involved, you have the pathogen itself with its own characteristics, you have the patient with the behavior by which they go to access treatment. You have the pharmacies, drug shops selling medicines without prescription, and you have some of the patients. The patients where that you get the sample from, so different characteristics. Recruiting participants to this group. So we got them from they came, the first entry was the clinic. And then the doctor said, okay, do you have a UTI? By looking at hearing their story, they would determine whether they need lab test. And then they would send the patient to go and get a urine sample, bring it to the lab, and then the testing of UTI would start. If they are found to be positive, then they would be asked to sign a consent form, and after signing, they would request for a visit to go to their homes, and then also look at interact with the contacts at home. So that's the community to check for. So in this one, we're looking at what is the burden of UTI among people presenting or diagnosed with UTI-like symptoms. That's the question we answered with this. And the outputs would be cases with UTI symptom, community health care workers, clinicians, and the centers. The other one was mapping the treatment decision-making, how they made decisions. And this one, we did it using what we call a mystery client study. So you get people who pretend that they are sick, and they go to the drug shop or pharmacy and ask for antibiotics. And then they come back, they've already noted down the behavior of this pharmacist or this drug shop owner while they were there. So they've come to your shop, you thought they were usual customers, but they were mystery clients, they were masking, they are kind of undercover reporters. And then we found that over 90% of the drug shop owners and pharmacists in the area were giving out antibiotics without prescription. So mystery client study is one of the best ways to study behaviors or epidemiological issues without doing any problem. And this is another one, mapping those who are providing antibiotics with our mystery clients. And the questions that we're asking here were, what is the antibiotic provision landscape for UTI pathogens in these populations? What are the provision practices and knowledge among different antibiotic providers and what factors influence the antibiotic offered. What qualitative aspects of client-provider interactions are particularly important for determining individual patient pathways of antibiotic use. So several questions that we asked under that objective. Then we also looked at how we train the mystery clients, how we standardize them so that they know what to ask. They don't go and then start behaving badly, and then the drug shop owner or the pharmacist would realize that there are mystery clients around. And we use tools like direct mapping using Epicorrect. Epicorrect is a digital epidemiological tool. It can kind of administer questionnaires. So you can collect a lot of data using questionnaires that are in Epicorrect. It can take pictures. So the pictures you take while you're collecting data, you can upload them into Epicorrect, and then all the data is merged. And then you can also do what they call micro react. You can see the points, the hotspots on the map that where there's more antimicrobial resistance. So it's a very good tool that I would encourage you to use in Indonesia. It's an app. It's free. You can download it from Google and use it on your smartphone. And you can go. If you have a questionnaire, you go take administrative questionnaires. You take the GPS coordinates. It can take GPS coordinates of the place where you're sampling, and then all that information, when you bring it, you can translate it into a map, so you know which areas give you more antimicrobial resistance than others. Now, finally, we look at sampling and data generation framework. So this one, I wanted to treat it in a way that when we are sampling, what are we doing? What are we looking for? Because we have talked about different sampling approaches. It could be random sampling. It could be purposive sampling. It could be sampling over time, a time frame. So different ways we can sample. But why do we sample? And when do we collect the data? Because for a long time, people thought, oh, if I'm collecting the sample, there's no need to collect data. I want to tell you that data collection starts even before you collect the sample. The first data set is when the doctor is taking the history of the patient. That's data. Then they send the patient to the lab or wherever you go to the field, you find the patient and you take the sample. Then where you have taken it from, the geographical location, the people you found there, how they are interacting, where they live, whatever behavior they have, you also record it. Because this is very important, especially for genomic surveillance. If you're going to have genomic data, say you've sequenced isolates and you want to make sense of transmission dynamics, there's no way you can do that without understanding the epidemiology of the specimen or the participant that you've got. So there are 4 questions that are normally asked when we are collecting specimens. The first question is why? Why am I collecting this specimen? It could be that someone is sick and you want to do a diagnosis. It could be that there is an outbreak and you want to do some surveillance and check what is causing the outbreak and inform the control teams. it could be discovery. You just want to discover something new. And so you're exploring. Then the functions of that, it could be that at the end of the day, the reason is that you want to diagnose, you wanted to treat infection, or you wanted to do disease surveillance. Now, what you want to do influences how you do it and the methods that you use. The next is the what. What do you want to sample? What sample type? Is it stool? Is it saliva? Is it urine? Is it blood? What kind of sample? Is it water? As you may know, now people are doing what we call sewage surveillance. In Scotland here now, we do surveillance of sewage to detect COVID and some other viral pathogens. And so regularly, samples are taken from this sewage and understood and analyzed. Then the other question is how do I collect this sample? Before you go out, you need to have ethics. You must have been approved by ethics to be able to collect those samples. You must have the preservatives or the collection vessels that you need to collect the samples, and the how, you need to think of what's the volume of the sample, how do I store it, what's the transport that I need, is it cold chain, is it hot, is it what? All that you have to figure it out before you go out to collect the specimen. You must have PPE. Is it a dangerous infectious pathogen? So you need to put on PPE. And then lastly, when should you sample? The frequency or the time or quarterly. So you can sample at a given time point or sample quite regularly or quarterly. And the reasons why you're doing that when is informed by the daily or spot or hourly collections, or it could be early morning collection, could be weekly or monthly collection of data or samples for further analysis. So this is what I call the sampling and data generation framework. Remember, as I said, data generation begins even before you collect the specimen. So do not wait, say, okay, now I have my intervention is working, I've used this compound and it is working. Now let me go and look for the cases. So you really need to be organized and make sure that you've thought about ideas right before you start. So our take home is our learning outcomes. Hopefully we have been able to describe or to define the basics of epidemiological inquiry. We've been able to describe epidemiological study designs. We've been able to explain application of study designs to research in resource-limited settings. We've been able to define triage concept and how it applies to epidemiology. We've been able to explain methodology of sample and data collection. And we've been able to give examples of possible epidemiology research questions at master's level. And we've also looked at the role of epidemiology in conducting antimicrobial resistance research. Thank you very much for listening. And it's been a long talk. I hope you haven't been bored, but thank you very much for the opportunity to share this information And if there are any questions, please, you're welcome to ask. Thank you.
Okay, thank you so much, Dr. Wilbur, for your presentation. Because maybe Dr. Fauzi has trouble in the connection, I will now open the Q&A session. So to all the participants, if you want to ask question to Dr. Wilbur, please raise your hand and then state your question, or you can type your question in the column chat below.
I think we have one question from Eva Fitriana. Bu Eva, monggo silahkan.
Okay, thank you. Good afternoon, Dr. Wilbur and Dr. Fauzi. I'm Eva Fitriana Susanti, a master's student in epidemiology. If I'm not mistaken, based on the presentation earlier, I noticed that quasi-experimental design weren't mentioned. My question is, how can we conduct quasi-experimental research with minimal bias? Additionally, how can we ensure that confounding variables have less impact on the research? Even after controlling for variables such as age, incoming level, and educational level, there still seem to be many confounding variables that could affect the study results. Thank you, Dr. Wilbur.
Thank you very much for that good question. I think there are two questions in that. How can we apply experimental design in research without bias, and how can we control for confounding variables? So for experimental design or for designs, you can control for bias by the way you design. So making sure that your design is robust and meets all the requirements for that kind of study. Because quasi means that some of the recruitment is not really randomized. It's a bit of a mix of purposive selection and a random allocation. So you have to make sure that in your design, you separate it from your emotional attachment and you leave it to be objective. That will remove the bias even before you start the study. Confounding variables, it's very important to understand the context of your study. I didn't have enough time. I should have gone through issues of bias and confounding and how do you remove those issues, but there was not enough time. But confounders are removed at design. That's why we talk of controls. You're looking for a control that gives you the best shot at understanding what is happening in the cases. Then the other level of removing confounders is at analysis. When you're analyzing, you make sure that you are objective. Or otherwise, you give your data to an independent person and they analyze it for you. In that way, you avoid the bias of trying to nudge your data so that you get a good result. You get what I mean? So analysis must not be biased and design must not be biased. And then understanding the context, the factors that might confound. I normally teach my students here about a case whereby in summer there was high sales of ice cream, but at the same time there were many cases of murder in the same town. And now somebody did an epidemiologic triangle and said ice cream, high rate of eating ice cream was responsible for murder or was associated with murder. But that association was wrong. So ice cream, the season, the summer season was a confounder between the two because here in the Western world, eating ice cream is very high in summer. And that time happened to be the time when there were many cases of murder. So they happened at the same time, and because they were being confounded by the summer season. So it's very important to understand what is the confounder and make sure that you remove it or adjust for it during your analysis. Thank you.
Thank you, Dr. Wilbur. Your response was very helpful.
Okay, thank you, Dr. Wilbur. Maybe any other participants have question to Dr. Wilbur, please raise your hand or you can chat your question in the column chat below. Okay, maybe Dr. Wilbur, we have, Bu Eva, do you still have any more question to Dr. Wilbur? Okay, okay. Maybe I will ask Dr. Wilbur still, while we wait for other participants. Is that okay, Doctor?
Yeah, go ahead.
Okay, I want to ask about what factor that influence most the antibiotics resistance in case of tuberculosis, especially in Africa, because from my experience back in my internship in my hometown, many of the drug surveillors contribute to the drug resistance of the patients or relapse cases because the drug surveillance itself is sometimes forgot about the time when they give the patient the drugs or the time also. Maybe, doctor, you can explain your findings to us. Thank you.
Yeah, so what causes the high risk of antimicrobial resistance? Is that your question?
Yes, doctor.
Yeah, so in the study that we did, we looked at a number of factors, both biological and non-biological. And what we found, one of the factors was that patients were accessing antibiotics from pharmacies and drug shops without any prescription. So they would walk in and ask for whatever medicine they want, and they would be given because a pharmacist or drug shop is there to sell. It's making money. So that's their source of income. And they've got a customer, so they sell the medicine. So, but what we did not do is, apart from determining that many people are accessing these antibiotics without any prescription, we did not establish a direct link. So, okay, go to the lab, is okay. People who have been getting these antibiotics without prescription, and then we see if they have UTI and then see if their bacteria have resistance. So, like an immediate real-time link was not established. But we can, we concluded that over time, this kind of behavior has contributed to the level of antibiotic resistance that we were seeing. Because there were many bacteria that we had multi-drug resistance, and there were some that had only two resistant to two antibiotics. So, meaning that people had been using the antibiotics for a long time, maybe even badly, and that caused resistance to grow. But also we found that there's also treatment seeking behavior, whereby someone goes to one clinic, they give them some antibiotic, they go home and they don't finish it, they go to another clinic, they give them, they go to another clinic, so they kind of move to different clinics or to different sources of medication before they go to the formal health care for advice. So these were all kind of factors that we think increase the risk of antibiotic resistance. And I want to kind of return a question to you. How is it in Indonesia? Do you can you access antibiotic without the doctor's prescription, or you must get prescription first?
So as I understand, we must get the prescriptions, and it's a bit stricter than in Africa, as I know that Africa can get more easily antibiotic, but in Indonesia it's still under control. But maybe there is some shop that sell the antibiotic without prescription, but mostly the people are usually buying the antibiotic with the prescriptions.
Okay, that's good. So now, when we talk about TB in Africa, apart from South Africa, other African countries, the drug resistance for TB is very low. Why? Because the TB drugs are protected. They are already prescribed by doctors. If you do not, there's no pharmacy or drug shop that is allowed to sell those drugs. So that is what has caused the low level of resistance. Compared to Russia, where I'm told that people were able to access those strong antibiotics for TB very easily, and then there's a high MDR TB rate in Eastern Europe. So there's no doubt that access to antibiotics in a very high way without regulation can increase risk of antimicrobial resistance.
Right. Agree. Okay. Is there any questions more from the participants?
I see
Ilyas. Ilyas?
Good afternoon.
Ya, silakan.
Okay, I'm sorry, doctor, because I can't open my cameras because there's a weak signal here. I want to ask about if I want doing a research, what the important criteria should I pay attention to when I choose a case?
Okay.
The questions, Wilbur.
So his question that if he's doing a research, what is the important criteria he should? Can you rephrase the question for me?
Ilyas, bahasa Indonesia saja Ilyas. Maksudnya di sini kriterianya seperti apa?
Ya, kriteria yang penting untuk kita ambil seperti itu, Pak.
So maybe I can translate like the considerations when we want to do the research in the epidemiology of the infectious diseases. So what consideration or what the importance key that we should take into account before we taking a concern for the research, Wilbur?
All right, very good question. The first thing I would say is to have a hypothesis. What's your question? What do you want to find? What are you asking? And now, what is your hypothesis about that? And then once you have your hypothesis, then you calculate the sample size, because you have a question And from your question, you draw a hypothesis. I'm trying to think of a quick easy hypothesis. You can say, okay, what is the burden or the prevalence of antibiotic resistance in Semarang city? And then your hypothesis can be high usage of antibiotics without prescription leads to antibiotic resistance. Now, you want to find out how many cases you should study in order to answer your hypothesis. And that's what we call the sample size calculation. So as an epidemiologist, one thing you should always master, you should know, is how to calculate your sample size. How many should you study in order to receive? So statistically, you work out what power do I want to get, 80% power or 90% or whatever, and then what's the sample size that will give me this kind of power in terms of answering my hypothesis. And then what methods do I use to get to what I want to get? So those are the considerations that you should always think about. And of course, do not forget about the ethics. If you're going to do a study that maybe involves human participants, then, or involves taking human samples or even animal samples, whatever, you need ethical approval. So that's a consideration. So what are the ethical considerations of your study? So at master's level, because you're going to graduate as an epidemiologist, you'll be going outside in the field to do research or collect data. What are the ethical considerations of what you're doing? The data that you're collecting, whom are you collecting it from? Have they consented? Are they happy that you use their data? Are they happy that they take you take their photograph? Are they, so what are the ethical considerations of your study? And very important that you have clear objectives. But objectives become easy if you have a question and now you say, okay, this is how I can answer this. What these are objectives that are actually under my question. The objectives should be smart. They should be time bound. They should be measurable and simple or smart. Simple, measurable, achievable, time bound. Realistic, time bound. So smart. S for simple, M for measurable, A for achievable, R for realistic, T for time bound. So that's what we call smart objectives. Don't start doing things like by the end of the study, I will understand, or they will understand. Understanding is not easy to measure. So you cannot measure understanding. But you can describe, or you can identify, or you can determine, you can estimate, you can have things that are measurable are the ones that you go for and you can achieve in a given time of in the time you have. I mean, your master research will be like, if you're lucky, it will be like 1 year of and so that's a short time. If you give yourself too many objectives, or you may find that you're not able to finish your research in time.
All right. Thank you, Wilbur, for the answer. I hope it answered the question from Ilyas. Are there any more questions? Oh, from Bu Eva.
Sorry, may I ask another question?
Sure, yes, go ahead, please.
Dr. Wilbur, many people in Indonesia are not aware of antimicrobial resistance. Can meat or eggs from resistant animals transmit to humans if we consume them? If so, it means that antimicrobial resistance is a very significant and urgent issue that needs to be addressed. Are there any countries that have successfully dealt with the issue of antimicrobial resistance? And how can we, as an epidemiologist, contribute to addressing this? Thank you.
Thank you very much, Eva. Your question has a number of questions. How can we how can you contribute to reducing antimicrobial resistance? Are there countries that have successfully reduced antimicrobial resistance? I can say countries in Europe, Western Europe, Scandinavia, North America, UK, they've managed to control antimicrobial resistance. And reason being that they put in place very strong antibiotic stewardship programs. So it's difficult. Like for me now, if I feel unwell, I can't just rush to a pharmacy to pick an antibiotic. I will not get it. I have to first go to the doctor. The doctor will listen to my story and decide whether I should have an antibiotic or not. So with those strong antibiotic stewardship programs, they've managed to control antibiotic. They have not brought it to zero, but they have controlled it. They've at least reduced the rates. Can animals spread to humans? Yes, because especially tuberculosis. You know, bovine tuberculosis, which is caused by Mycobacterium bovis, and then the human tuberculosis, which is mainly caused by Mycobacterium tuberculosis and other species, Africanum and others. The Mycobacterium bovis can move from cows to humans or from other small animals. So if we go to the field, pick up these animals, maybe while we are processing them, we touch our mouth or our nose, the TB can easily get into our bodies. So there's a chance that animals can transmit to humans. We did a study from Nigeria. We got tissues from cows, which were about to be slaughtered for beef. And we took some tissues, we extracted RNA, we did PCR, and we found a lot of TB. 44% of these cows had TB, and some of them had very many granulomas of TB around the liver, around the lung, and other parts of the body. Like parts that you thought maybe there shouldn't be TB, there was TB there. So actually, liver had more TB than the lungs. Can you imagine? So, and people normally like to eat liver. So it's easy that before you cook it, because we know cooking would kill the TB, while you are processing it and maybe you're cutting it up, whatever, you can easily touch your mouth or your nose, and TB can get into your body. And there are those who don't cook well, TB may survive and also get into your body. So what you can do as educated epidemiologists in Indonesia, one is you need to translate these biological terminologies of antimicrobial resistance, whatever bacteria, whatever, into the language that people speak. Because what we found when we did a study in East Africa is that we found in the local languages, there's no word like antimicrobial resistance, because antimicrobial resistance is a new word that is emerged in the English language. It's not something that's not a word that evolved with human language. Now, those words that we know in biology, in medicine, they are not known in our languages, in our mother tongues. So what we need to do is now to create words for these biological terms and make them in our language so that our people can understand these words. So, and that's how we can increase awareness. But the reason why people are not aware is because people who are educated, who have gone to university, you are speaking your own language that you have studied in class, and then ignoring the community who are speaking another language. So we must put these words into the language of the community. Two, we must put in place antibiotic stewardship programs to make sure that access to antibiotics is regulated, and so that people receive antibiotics when they really need them, not just to eat them as if they are eating chocolate. I think those are two areas that we can help, and of course, prevention of infections. Because if you prevent infection, that means the pressure for using antibiotics is reduced. So if there's anything that can be done, prevent infections, then the pressure for using antibiotics will also be used. So three things. One, increase awareness by translating the biological knowledge words into the local language that people understand. Two, institute antibiotic stewardship programs. Three, infection prevention and infection control programs, both in healthcare facilities and also in the communities.
Okay, thank you so much, Wilbur. Is there any more questions from the students, please? No more questions? Okay, Wilbur, I think that's enough for the lecture, because it's just too long for you and too early for you to wake up and then talk about the lecture with a very heavy lecture to the students. Once again, thank you so very much, Wilbur, for giving us the lecture knowledge insight to us. And so very much thank you, Wilbur. And then I hope that I can see you in person in Semarang or in the UK after this. And then stay healthy, Wilbur, and really hope to see you again in person. Thank you, everyone. That's it from the Wilbur, and then I will return to our Master of Ceremony, Vina.
Thank you very much, and have a good day or good evening.
You too, Wilbur.
Bye.
Thank you, Dr. Wilbur.
Thank you so much, Dr. Wilbur, and thank you so much to Dr. Mufauzi and to all the participants for the question. And before we really end this session, I want to ask Dr. Wilbur to give us some closing statement and maybe some motivation words for us, the epidemiology students, to keep up our spirit in studying epidemiology. Maybe to Dr. Wilbur, time and place is yours.
Thank you very much, Arista, and for being a very good moderator. And thank you, Dr. Fauzi, for having invited me. It's been a joy and pleasure to be able to speak to you. And I thank you for the good questions you have asked, very brilliant questions. And I look forward to keeping in touch. Epidemiology is one of the fundamentals, the foundations of medicine. Without epidemiology, we cannot really do medicine in a proper way, and also public health. Public health interventions cannot work without epidemiology. And now we have what we call these advanced tools of genomic surveillance, whereby we are sequencing different microbes, bacteria, malaria parasites, fungus, name it, everything now. We can sequence it and get these genomes. Remember, these genomes are meaningless without epidemiological data, without the metadata, that information that you collect around it. Where were the people? What disease are they suffering? Them? Whom did they contact? Where do they live? Whatever, all that information, because you cannot talk of transmission if you don't know the epidemiology of the genome that you're seeing in front of you. You can have hundreds of sequences in front of you, but if you don't have any epidemiology data, they mean nothing. So what you are studying is a very important subject, and you are very important professionals that your country and the whole world needs, because I want to be surprised if most of you are fished by other countries to go and work there and live in Indonesia, because you are hotcakes for this. Epidemiology is very important. And you're looking at these epidemics that we are getting almost at a daily basis, a new epidemic. It was not until just before we ended COVID, the monkeypox, mpox was emerging, and we thought it was going to stay down at endemic levels. It's now turned into another epidemic. So there's so many cases. Marburg virus just recently emerged in Rwanda. So while they were fighting mpox, Marburg came up. Then there's dengue fever outbreaks everywhere. Zika everywhere. Rift Valley fever everywhere. So the epidemics have become more frequent. So that means epidemiologists need to also up their game to advise on how we can prepare and prevent these epidemics from emerging again. So thank you. Stay energized and stay focused. Whatever you are paying your tuition, it's value for money, because you're studying the best subject.
Thank you, Wilbur.
Thank you so much, Dr. Wilbur, for amazing lecture today and the motivational words that epidemiology is the core of public health, and we need epidemiology to understand the disease so that we can prevent the spread of disease and promote the well-being of community. And I also want to thank Dr. Fauzi for leading the discussion, and thank you for all the lecturers and participants joining our visiting lecture today. And I hope in next opportunity we can meet and learn more about infectious diseases and epidemiology research. And thank you, and see you again in another visiting lecture.
Thank you.
So much, Wilbur.
Bye.
Bye. I'll see you later. Bye.
Bye.